topic for the today's class is inflammatory bowel disease. This topic is very important just because the incidence is rising day by day. There are many factors for that. We'll discuss in detail. Initially, it was not that prevalent, but due to dietary modifications, the living lifestyle is causing the increase in the incidence of this. The second last topic, and after the last topic, we will have a short test here in the class, and the marks will be included in the assessment. So whenever there is a class of carcinoma colon in the next month, we will be having a small test in the class. Lesson plan will remain same, starting from the etiology to the microscopic features and part of clinical feature and treatment. So today's learning objective is, after the end of the class, we should be able to define the etiology and pathogenesis of the IBD and differentiate between Crohn's and ulcerative colitis. That's a special question probably asked in the exam very frequently. Difference between the Crohn's and the ulcerative colitis. So today we are concerned with the two organs mainly, the small intestine and the large intestine. Starting from the duodenum up to the rectum. This histology. Villi, microvilli, lymphoid follicles, we have discussed in last class also. Same then, two layers of muscle, circular and longitudinal. Now, IBD is a chronic disease and it's an immune mediated disease. This is a dysregulation in the immune reaction of the body towards the antigen. It may be in the form of microbial or some other. And it is more prevalent in the high socioeconomic. Epidemiology incidence is more for the Crohn's disease, minor. Otherwise, both are equally prevalent in the society. Age is almost same, so it is very important to distinguish between these two entities. The main thing is smoking. Smoking gives a small protection factor towards the ulcerative colitis, and this will cause the disease of Crohn's. Oral contraceptives increase the incidence of Crohn's disease, no effect on the ulcerative colitis, and appendectomy is protective for the ulcerative colitis. So as discussed, etiology may be in the form of infectious agents like Salmonella, Shigella, Campylobacter, Clostridium, or the diets rich in animal protein, sugar, sweet, oil, fish and shellfish. While the breastfeeding and the vitamin D are protective for the disease. So this is the interplay between all these factors which affect the enterocyte, the epithelial cell of the intestine, which is in the form of microbial flora, environmental factor and the genetic factor. The most important gene in this is not to. Please note of it. Human infant is born sterile. There is no microbial flora in the whole of the body of the infant. So when some microbial flora, then there is a immune activity against that antigen. But if we inhibit that, if we give the sterile food or the sterile environment to the kids, then there is no production of such antibodies. And at later stage, such immunity develops and which may cause a excessive harm to the body. So that is why it is very important to expose the kids at the early stage for the antigenic stimulus. If there is a development of tolerance for those antigens. And the environmental factors may be in the form of antibiotics, the diet, insects, smoking, stress. And there are multiple genes isolated, but there is no direct positive relation between the gene and the disease. But the presence of such genes may increase the incidence of the disease in such way. So there is association of few genes with other diseases also. So these diseases may coexist in a patient of IBD, like diabetes mellitus, because all these diseases are also immune related. Diabetes mellitus, rheumatoid arthritis, psoriasis, ankylosing spondylitis, bronchial asthma, and SMA. So what's the reason to tell at this point regarding these diseases? Because we are treating these diseases also with the help of immunomodulation. Some immune suppressors or immunomodulators we are giving. So sometimes the disease may subside, the ulcerative colitis and Crohn's disease may subside with the treatment of such diseases, or simultaneously that may aggravate. So we have to keep the balance between these diseases if they are coexisting in the patient during treatment. Mucosal immunity is with the help of IL-10 and the Th17 receptor. So if there is modification in the gene producing these factors, there may be increased incidence of the disease. Excuse me. Autophagy and cellular stress responses are mediated through ATP16L1 and IRGN. So again, if there is modulation in these genes, there is increased incidence of the IBD. Then host microbial interaction may be by the Clostridia species, Bifidobacterium, and the other multiple species which produce butyrate. And butyrate is a product which enhances mucosal barrier function and increases epithelial proliferation and immune regulation. Again, the important thing in this disease pathogenesis is the CD4T helper cell. Type 1, type 2, and type 17. Through multiple pathogenic mechanisms like transmural granulomatous inflammation, superficial mucosal inflammation, and neutrophilic recruitment. So, if again there is some modulation in the activity of these cells, there is increased chance of the disease. So now the morphology. Table is important. We have to differentiate between ulcerative colitis and Crohn's disease. The most important thing is that ulcerative colitis is a continuous disease. So it spreads in a continuous manner in the colon. So it's a predominantly disease of colon starting from the rectum. It may proceed retrograde fashion towards the sigmoid colon. So if it is limited to the rectum, then it is known as ulcerative proctitis. If involving sigmoid colon also, then proctosigmoiditis. And if whole of the colon is involved, then it is known as pancolitis. But sometimes, generally in ulcerative colitis, ileum is not involved. But sometimes the disease spreads to the terminal part of the ileum, causing the backwash ileitis. But in general, the ileum or the small intestine is spared in ulcerative colitis. While the Crohn's disease is a segmental disease and it causes the transmural inflammation, transmural involvement. That is the whole of the thickness of the intestinal involvement. And it can involve any part of the intestine, but specifically it spares the rectum. So if there is rectal sparing, then it's Crohn's disease, and if the small intestine is not involved, then it is ulcerative colitis. So what can be the morphology? The Crohn's disease starts with the abscess ulcer, and if there are multiple lesions, they coalesce and form the elongated serpentine ulcer. So elongated ulcers are also present in which disease? Which infectious disease we discussed in the last class? Typhoid. Typhoid are the longitudinal ulcer and the transverse were the tuberculosis, which we have seen in the broth specimen also during practical. So the ulcers in the Crohn's disease are also serpentine elongated. There is ulceration and the sparing of the in-between mucosa, which gives the cobblestone appearance for the intestine. You see in the broth picture. Then as the involvement is, you can see transmural. So the inflammation goes deep down into the serosa, which may cause the fissure and finally into the fistula. And these fistulas may open into other intestinal bowel loops or in the surrounding organs like urinary bladder, causing the fistula. And if it is reaching up to the surface of the intestine, then the mesenteric adipose tissue frequently extends over the serosal surface, which gives the appearance of the creeping fat. While in the ulcerative colitis, there are isolated islands of regenerative mucosa, which is often bulging into the lumen. There is ulceration and then there is regeneration, which may give rise to the appearance of pseudopolyps. These are not true polyps because the nearby area is having ulcer and in between there is a growth of the mucosa of the colon, which gives rise to the appearance of pseudopolyps. And sometimes the tip of these polyps may fuse, causing a mucosal growth. As this is a chronic disease, there is mucosal atrophy with smooth mucosa. We all see these features in the gross appearance. And inflammation of the muscularis propria and the neuromuscular dysfunction give rise to the megacolon. The colon becomes dilated because there is no control of the neural bundle and the wall is thick. So these are the distinguishing features for Crohn's and the ulcerative. Serositis, as we said, there is a transmucosal and transmural involvement in the Crohn's disease. The serositis will be present in the Crohn's disease, not in the ulcerative. Thick bowel wall is present in Crohn's disease. Picture, as it is going deep, there will be more fibrosis in the Crohn's disease. So stricture will be common in the Crohn's. Mucosal edema is also present in this. Then fistula, specific feature performed. Rectal involvement, as we discussed, is present in ulcerative colitis, but rectum is spared in Crohn's. Distribution-wise, Crohn's disease is present 30% specifically in colon, 30% in both colon and small intestine, and 40% in only small intestine. So it can present at any part of the intestine. And transmural inflammation, it is going deep into the up to the cirrhosis and may go into the fat also. While in the ulcerative colitis, it is starting from rectum, going retrograde fashion to sigmoid and transverse, but the involvement is continuous. There is no skip. And pseudopolyps, the unaffected mucosa or the hypertrophy of the mucosa along with the ulcers on the side of that mucosa is producing the pseudopolyps. What is the difference in the microscopic features and macroscopic features? Crohn's disease, as we discussed, is involving ileum and colon both, while ulcerative colitis is involving colon only. Distribution is continuous and this is stiff lesions. Picture more common in Crohn's. and wall appearance is thick in Crohn's and thin in ulcerative. Now the microscopic features for both the diseases, the inflammation is transmural involving all the layers. So whenever you will see the slide of the Crohn's disease, the inflammation will be going up to the serosa, while in ulcerative colitis it is limited to the superficial layer in the mucosa and the submucosal layer. Pseudopolyps, as we discussed, are predominantly present in the ulcerative colitis. They may be present in Crohn's, but they are less. Ulcers in the Crohn's are deep, just like knife, as we saw in the last picture. Where the ulcers are going deep, so they are the knife-like appearance. And ulcerative colitis, the ulcers are superficial and broad. The lymphoid reaction is marked in Crohn's. Fibrosis, as this is going deep, the fibrosis is more in Crohn's. Serositis, again common in Crohn's. And granulomas, it's a specific feature of Crohn's disease. It is not found in ulcerative colitis. If you can find the granuloma in a slide of IBD, it's Crohn's disease. And what is specific for that granuloma? It is non-caseous. So here we can see the colon. You can see the whole length of the colon is involved. Hemorrhagic picture, and you can see there is loss of mucosal hole. It's flat mucosal. This is pancolitis. Elective disease is red, granular mucosa on the colon, and here there is atrophic. Here you can see the granular mucosa, here it is flat. Then there is a sharp line of demarcation between the involved colon and uninvolved colon. Here you can see the hemorrhagic or the congested appearance. The sharp demarcation between the active ulcerative colitis and the normal. Here you can see these are the protruding areas. These are the inflammatory polyps. But these are not true polyps. They are giving the appearance of polyps just because the surrounding area is showing the ulcer. And these are the mucosal phases. These are the microscopic features. Here we can see a gland, and there is acute inflammatory infiltrate inside that gland. This is known as cryptite. And this is normal lining of the mucosal glands of intestine. But here we can see this mucosa is just like a stomach wall mucosa, pyloric mucosa. So this is known as pseudopyloric metaplasia. And in this picture, you can see the inflammation is limited to only these layers, the mucosa and the submucosa. These deeper layers are uninvolved. So the disease is superficial. So all these features belong to ulcerative colitis. Now this is Crohn's disease. These are the serpentine ulcers going through the length of the intestine. These are pseudopolyps protruding into the lumen. And after healing, it has narrowed the lumen. So it's a picture formed after the healing of those ulcers. Here, there is perforation in the wall of the intestine. As the inflammation was transmural, it has gone up to the serosa and into the fat and causing the perforation. And if this is in contact with some other organ like intestine, this may cause the formation of the sepsis. And here the fat is coming to the area where the inflammation is coming. So this is known as creeping fat. Now these are micro photographs of the Crohn's disease. Here you can see the inflammation starting from the mucosa is going deep up to the muscle layer and up to the serosa. So this is transmural involvement. And this is the granuloma present in the wall of the intestine. Formed of epithelial cell, but you can see there is no necrosis in between, which was present in the tubercular lesion. We discussed the histological features. So what can be the differentiating feature? Granuloma present in Crohn's disease, not in ulcerative colitis. Fissures and fistula in Crohn's, not in ulcerative colitis. Then Pennant cell metaplasia is present in ulcerative colitis. And the involvement is patchy in Crohn's, while ulcerative it is diffuse. So depending on these gross features and microscopic features, what can be the clinical findings in the cases? In the ulcerative colitis, there is diarrhea, which is predominantly nocturnal or the post-prandial. After having meal, patient has a feeling of diarrhea, and this is temporarily relieved by the defecation. There is rectal bleed due to the ulcer, tenesmus due to inflammation. What is tenesmus? Crampy abdominal pain. Then passage of mucus and crampy abdominal pain. In Crohn's disease, the features will depend upon the site of involvement. If it is involving the ileocolitis, then the right lower quadrant pain, and this is relieved by the defecation. If the jejunum and ileum is involved, there is loss of fat in the stool known as aciduria, and simultaneously malabsorption of many nutritional things which may lead to the nutritional deficiencies in the form of iron deficiency, vitamin D deficiency, B12 deficiency. And if it is involving the colon and the perianal area, there is low-grade fever, malaise, and diarrhea with crampy abdomen. So the Crohn's disease features will depend on the site involved. Now, depending on these features, what can be the complication for the disease? As we discussed in starting, the layer is thinned out in the colon to give rise to the toxic megacolon feature, where there is dilatation of the colon, which may lead to later in the perforation. While in Crohn's disease, due to the healing, there is stricture, which may cause the obstruction. There is formation of fistula in between the bowel loop, with the bladder, with the vagina, or they may form the fistula with the skin surface, abdominal skin surface, or the perineum. There may be nutritional deficiency due to malabsorption of iron and the protein. And the important thing is colonic carcinoma. This is a complication mainly in the ulcerative colitis. This will depend on the duration of the disease. The longer the disease, more the chances of the malignancy, and the extent of the involvement and the nature of the inflammatory agent. What's the treatment for the disease? As this disease is occurring due to inflammation, so the major treatment part is by the anti-inflammatory agent. Initially, we used to give salicylate, which was non-specific, but now we are giving the specific drugs, which are the immunosuppressive drugs in the form of corticosteroids or the biological therapy. Nowadays, lots of drugs are under trial for this disease. Anti-TNF antibodies, because it's a immune-mediated disease, so we want to decrease the TNF load of the body. And antibodies against other cytokines, because all the inflammations are somewhere related to cytokines. Now we have started surveillance program also for the IBD patients. As the risk of colonic malignancy increases after 8 to 10 years of the disease, so we start doing the colonic biopsy at a regular interval, just to rule out any dysplasia in the biopsy. If we find that, we can treat this with the help of colectomy. But if the disease is associated with primary sclerosing cholangitis, then we start the surveillance on the very first diagnosis, because there are more chances of the malignancy. So multiple biopsies are taken from varied sites, and what we want to rule out is dysplasia, which can be in the grade of mild, moderate to severe. And if it is more, then we go for the colectomy, the partial colectomy, or we can go for the cancer, which will decrease the chances of the malignancy. There are some extraintestinal manifestation of the disease also, because these are related to immune system. So there may be nodule formation in the skin, which can be due to granuloma, clubbing of the finger, And sometimes these two features, cutaneous nodules and clubbing, may develop before the disease develops. So we can have a index of suspicion if the patient is having these two features in the form of cutaneous nodules and the clubbing. Then uveitis, migratory polyarthritis, sacroiliitis, ankylosing spondylitis, erythema nodosum, pericholangitis, and more specifically primary sclerosing cholangitis. Any questions related to the topic? So we'll do 25-year-old woman is brought to the emergency room with symptoms of acute intestinal obstruction. The patient has an 8-month history of blood-stained diarrhea and cramping abdominal pain. So these features are guiding me to the diagnosis of inflammatory bowel disease. Her temperature is 38, 101 degrees Fahrenheit, and respiration 32 per minute. There is abdominal tenderness to palpation. Lab studies show moderate anemia, serum hemoglobin 9.3. Microscopic examination of the stool reveals numerous RBCs and WBCs. So there is presence of blood in the stool. CT scan of the abdomen shows massive distension of the transverse colon. Which of the following is the most likely underlying cause? Anyone? Ulcerative colitis, and this is a picture of toxic megacolon. 27-year-old woman presents with a 9-month history of bloody diarrhea and crampy abdominal pain. 3 weeks ago, she noticed that her left knee was swollen. So this is again extra-intestinal manifestation. Knee was swollen, red and painful. Her temperature is 38 degrees. Respiration are 32, and blood pressure is 130/90. Abdominal palpation reveals tenderness over the left lower quadrant. Lab studies show moderate anemia with a hemoglobin level of 9.3. Microscopic examination of the stool reveals numerous blood cells. Diffuse red, leaving friable colonic leukocytes visualized by colonoscopy. Colon is subsequently removed and the surgical specimen is thrown in the patient. Again, the diagnosis is ulcerative colitis because there is colonic involvement first of all, and there is sharp line of demarcation. 44-year-old woman complains of having yellow eyes, dark urine, and recurrent fever for about 3 months. So these features are for yellow eyes, dark urine, from the jaundice. So some liver is involved. On physical examination, patient is thin and jaundice. The liver edge descends 1 centimeter below the right dorsal margin and is non-tender. Lab studies show elevated serum bilirubin, normal AST and ALT. So the hepatocellular jaundice is not present. AST and ALT gives the indication of the involvement of hepatocytes. But the bilirubin is increased. So there may be some other reason for the increase in the bilirubin. And an elevated level of alkaline phosphatase. So what this signifies, alkaline phosphatase? If in LFT, AST, ALT are normal and alkaline phosphatase is increased, what is the indication? It's an indication of some obstruction in the tract, in the biliary tract. Now, endoscopic retrograde cholangiopancreatography demonstrates the beaded appearance of the extrahepatic biliary stream. Which of the following is the most likely underlying cause for the diarrhea in this case? Anyone? Just read, we have only one diagnosis out of all. So there may be ulcerative colitis, but what is the reason? You can see by this slide. The last point in the slide is primary sclerosing cholangitis. So the patient was suffering from primary sclerosing cholangitis, the beaded appearance of the biliary tree, and this primary sclerosing cholangitis PSC is more common in ulcerative colitis. Now Now, 21-year-old man is brought to the emergency room with symptoms of acute intestinal obstruction. Temperature 101 degree Fahrenheit, respiration 25 per minute, blood pressure 128. Physical examination reveals mass in the right lower abdominal quadrant. Right lower abdominal quadrant. So, what is the site of involvement? Somewhere near cecum and ilium. The patient subsequently undergoes surgery and the segment lesion involving the terminal region is resected, shown in the image. Which of the following is the most likely diagnosis? Wrong. 24-year-old man is brought to the emergency with symptoms of acute intestinal obstruction. Temperature 101, respiration 25, blood pressure 128. Physical examination, right lower abdominal quadrant, mass. Laparoscopy, there are numerous small bowel strictures and a fistula extending into the loop of the small bowel. Again, the diagnosis is